world, literally. And there are at least 4 or 5 different focuses that we really push on. Economic development, mentorship, leadership, and then health and wellness. And so this is health and wellness is one of our pillars that we definitely like to, talk to our mentors about. And so tonight we thought it would be a wonderful opportunity to partner with Community Health Centers of Arkansas to talk about an issue that isn't really talked about a lot in Black spaces, in Black communities. And since we have a captive audience of mentees and other folk, we thought, okay, let's bring the conversation to the brothers, right? So that we can educate ourselves and we can have this conversation so people can be educated. So tonight, we're just gonna have a conversation. This is gonna be a conversation with experts and practitioners. In a minute, I'm gonna introduce each one of the panelists. Then I'm gonna go through and do a data walk and kind of go through what HIV looks like from the United States all the way down to Arkansas. And then I'm gonna engage the panel in some questions. And then we're just gonna chat. And then around 7 o'clock, everybody out there who's watching this discussion, you'll have an opportunity to ask questions. So if you do have questions, put them in the chat box and I'll be monitoring them and Sarah will be monitoring them. And at the top of the hour, we can pull some of those questions in so that the audience will have an opportunity to engage our panelists. And so that's kind of like the overview of tonight. I'm gonna do some quick introductions. I'm going from my right to left. The brother right next to me is Mr. Kevin Holmes. He's been in the field of HIV prevention and LGBTQ wellness for over 10 years. He currently serves as a liaison to the Community Connectors Program and also an LGBTQ outreach coordinator for the infectious disease branch of Arkansas Department of Health. He has done a lot around this issue of HIV and LGBTQ relatedness, and so we're really happy to have him here on our panel. Next, we have Miss Lashannon Spencer, or I would call her my big sister. Been knowing her for 20 years. She gave me my first professional job back at Big Brother, Big Sister, almost 20 years ago. She's the Chief Executive Officer of Community Health Centers of Arkansas, has been that way for the past 4 years. Lashannon is regarded as a thought leader regarding access to quality healthcare services and vulnerable populations. And just before we started, Shannon has been itching to get into the debate on bringing students back into the classroom. So she was schooling us on all of the various challenges with that and was unapologetic about her position about, sending these babies back into this space so that they could possibly contract this virus. And so that's just part of who she is. And then finally, we have Dr. LaMar Hasbrouck, who is the Managing Director for DLM LLC, a boutique consulting firm committed to improving human health. This brother is a nationally recognized person who has worked at the CDC, has worked at Morehouse School of Medicine, even done some work with Obama. I think I read in his bio. And so he has been known as the top doc in Illinois for the Governor Pat Quinn's administration. And so we're really happy to have such a person of such high caliber to come in and inform this conversation. And so these are going to be our panelists tonight. And so before I start asking questions, I put together a little quick presentation because I think in these conversations, framing is such an important thing. And if you start with the numbers, then I think it makes it real to people. And I found a few charts from Arkansas Department of Health and the CDC that I think can kind of help put some things in perspective. So I'm going to share my screen real quick. And the first screen I want to show is from the CDC, which talks about, at least for the past 4 years, the rise of HIV, AIDS in the various different populations, demographics. And as you can see, as you continue to keep going to the left, you'll see that African-American gay men, Latino gay men, African-American women, and white gay men or bisexual constitute the highest contraction rate of HIV. But is Black men, Black gay men who are on the rise in this category. And then the other part I thought was really interesting is looking at where HIV, the new diagnoses are coming from. It's coming from the South. And when I saw this graph, I thought it was very, very telling. And if you look at Arkansas, you can see right smack in the middle where we're at in Pulaski County, you can see that it's a very, very high rate of contraction of the disease. And we know that most African Americans live in the South. And so to understand this completely, we have to understand that this is a disease that is ravaging our communities all throughout the South. And then finally, the last slide is some local numbers. I found this on the Arkansas Department of Health that kind of shows the rise of new HIV diagnosis in the past, and from 2008 to 2017. And as you can see, Black folks make up a very significant part of these new contractions. And so this is what the data looks like nationally, and this is what the data looks like regionally, and this is what the data looks like here in Arkansas. So based on that, I want to go back and talk to my panel and begin to ask them some various questions around these broad buckets of themes that we decided to address tonight: the myths, the truths, and the resources. And I want to start off with this question, and I want to pitch this to Kevin. Some believe that HIV is simply a problem for gay people. Why is that incorrect?
I feel like it's been concentrated in the gay community, because the gay community, when it first came to pass, it was GRIDS, which was a gay white male's disease. And so we've never really educated ourselves, and we've taken that and we've ran with that. However, anybody who has unprotected sex puts themselves at risk for HIV, no matter their sexual orientation, no matter their gender, no matter their race.
What about you, Dr. Hasbrouck? What is your take?
Well, I mean, I'd agree with Kevin. It is still largely a gay male problem in all populations of color. So part of that is still true. But I think the impression and the stigma was so deeply imprinted when this disease really hit the front pages and hit everyone's lives in the early 80s, that it still can't shake that particular stigma. And sometimes folks falsely believe they're out of harm's way if they're not in that category, that risk category. But as we'll probably discuss, there's plenty of risk categories. I think Kevin touched the most important one, is just unprotected sex, regardless of who you're doing it with, how you're doing it, and what you like. If it's unprotected, you're at risk.
Absolutely. Shannon?
I'm going to echo what the gentleman has said, and just also, amplifying the importance of just communication. And so, when I think about the word ignorance, some people may think that that's too harsh, but I think we as a Black race need to be accepting with talking about sex. Sex is always this taboo subject that no one wants to really talk about, but why? And I think you need to start at an early age with really embracing the importance and just the topic of sex, because that's where you would be afforded the opportunity to get comfortable. And when, Doc and Kevin was talking about just gay men, so you have some bisexuals, and then you have men that are on the down low, and just really having that honest conversation with people that you're intimate with. And then I also think about what's wrong with just even asking someone, hey, let's go get tested together, or what's your status, and just being open to have that conversation.
So let's go there, because Shannon, she always goes there, right? let's talk about in our communities, like why is it that Black folk shy away from talking about this issue? I mean, in social sciences, we have this thing called respectability politics, where it kind of governs. There's certain things you just don't talk about, right? And we know that specifically the church doesn't really. Some churches, not all churches, but some churches are very, very conservative and really don't have spaces for, those kind of conversations. So, I mean, just based on, the work that you've done, like what is it? What's the barrier? What's the number one barrier for us to have these kind of open conversations? And I'm gonna pass that to you, Dr. Hasbrouck.
Well, I will say that we are a community, a culture that has deep spiritual roots. And we know that the church has been that pillar in our community, even when we didn't have a community, when we were, in shackles. So we are a deeply religious, I will say, people. Many of us are concentrated along the Bible Belt, which is also the stroke belt and the hypertension belt and others. So I think that, again, there's a clash between the religiosity and the faith that we have, and then the taboo. And because it has this stigma, this label, this is a gay male disease, then I think it's kind of hard to reconcile that. So for fear of the stigma, for fear of the reaction to some folks, we still have. We have to take this disease into the shadows sometimes, and into the back rooms to have the conversations. But I will tell you what I've seen when I was the leading the state health department in Illinois. Something that really worked to kind of cut through that was building in tools that allow folks to learn their status anonymously and not in the local health center in their community. So I can go out somewhere else and discreetly get my test. I can get anonymous text and things like that for reminders for my medications. Other things, kind of using digitally enabling a person to manage their disease and also to manage their tests and their test results. So if you can take that away and they feel like they can do it in private, in confidence, then I think you can begin to break through that. It doesn't address the open conversation, the open forum, which we really need to get to, but it is at least a step in the right direction.
Kevin, you want to jump in?
Yes, I think Lashannon actually speak on it earlier about the importance of talking to your children at an early age. And at some point, we have to break those generational cycles of not talking about it. I know in parts of Maryland and DC, they start in the 5th grade. They start comprehensive sex education in the 5th grade. And then oftentimes when our kids come to us about the things that they're feeling, we just automatically dismiss them and tell them not to do it. And we don't necessarily think about the things that we've done, because a lot of us was born out of wedlock, if you want to call it. A lot of us was born out of wedlock. Our parents weren't married. Some of our parents were teenagers. Some of our parents were just, oops, my bad, And so we have to have these real conversations about sex and making sex normal, because it's very normal. That's how we all got here. So I feel like we just need to normalize sex, the sex talk overall.
Absolutely. Shannon?
Kevin, you said normalize sex. That already exists. If you have children in COVID-19 and children are, there's a lack of activities for them to actually get out and to be able to mingle with other children or other teens. So they're watching not so much Netflix, but YouTube or TikTok, and sex is there. We may think of it as sex, but sex is displayed in so many different avenues today to where kids are already thinking about it. It's on their brain, but we just have not had the opportunity to really take in the time to sit down and really talk to your children or child about that. It's there. Kids are seeing so much more today than yesterday. And as I think about my young daughter, whom, I at times can be that tiger mom, I can't always control her from looking at YouTube or looking at, wanting to be like these TikTok stars. It's sexual. I mean, you even have it on Disney Channel. So we must really start sitting down to educate our children at that early age, instead of allowing the television to educate them about this critical topic.
Kevin, you used the word normalize, and I want to go to the extreme now. I want to flip it, right? So I work at a college campus, and it's always amazing seeing the new types of students that the college keeps bringing in, and some of these students who have no memory of 9/11, some of these students who did not know a world without, cell phones and so on and so forth, or didn't have a context. For some of us, I think we're all of a certain age when AIDS came out, right? Or HIV came out. And it was you know, this thing, and it was scary. There was all these kind of things that were going on. And so in talking with my students, one of the things that I've come across them saying to me is, well, you know, there's medicine out there. Like I could take it and I could still live a long life. So why do I need to be, you know, why I gotta do condoms and stuff? They equate it as just as like a cold or a flu or something like that. It's nothing that, have you come across, Dr. Hasbrouck or Kevin, those type of, you know, extremities where people just think that, okay, it's just like any other disease?
Sure, and I'll let Kevin chime in as well. I think that the good news is that AIDS has moved from an acute, get it right away, die within months or a year if you're lucky, a very painful death, a very wasting death and things like that, to now it's more of a chronic condition that you live with. You may not even die from it. You may die from something else while having it because of the medications and all the you know, all the progress in terms of treatment and management, all the screenings we do and all the things to keep people well when they have a depressed immune system. So there has been a little bit of lax, you know, going on because folks, you know, they look robust. You'll see a lot of, you know, you'll see a number of folks. I mean, if you go to, you know, some of the parades or celebrations, you'll see, you know, a lot of very fit looking men, you know, they're very proud of their bodies and very proud of their physical health. And, you know, and they don't look sick anymore. You know, they don't act sick anymore. You know, they have jobs. And so now it's a condition that you live with, much like diabetes. The difference is that you can't transmit to diabetes or other chronic diseases to other folks. And so there are medications that can really suppress, you know, the level of the virus in your body and make you essentially, you know, without any problems. But, you know, it's still there in your system, and it's still something that you really need to disclose and really need to manage and really need to be on top of. So, you know, it's been kind of a double-edged sword, you know, but you know, we made a lot of advances, but it doesn't entitle us to complacency. And I think that's some of what your question is getting at.
Right.
Yeah, I agree with that. I'm going to piggyback off of that because, you know, we want the stories of hope, and we want the people to say, you know, I can live a long, healthy life with this, but we also want people to understand the severity of it. It's not all peaches and cream, even if you're healthy and living with HIV, because you have to take your medicine every single day. And if you get sick from something else, it can affect the T cells that are trying to help you fight your HIV. And so a lot of it, we don't do the scare tactic thing anymore. It doesn't really work anymore, but I feel like we need a balance of, you know what I mean, things to actually talk about. When we talk about HIV, we can say, you know, hey, I'm living a long, healthy life, but it's not easy. And you need to say, well, you know, I can still transmit it if I don't take my medications. Right. And so I just think there needs to be a balance of both, so that people who are HIV positive can still have hope, and for people who are HIV negative to say, you know what, that's not something that I want to deal with for the rest of my life.
Shannon, you got anything to say?
You know, being the only woman on this panel makes it very interesting, because I just want to it's all about men, but women, the number is increasing for women just as well. And so, you know, we want to just say gay men, or bisexual, but you have men that have transmitted this disease to a woman. And, you know, they could be living a very healthy, prosperous life, and she becomes infected. I remember actually listening, I was at a documentary at UCLA in 2016, and a producer, she had actually done a panel discussion of women that you would never assume was positive, and they were actually married. And they never had assumed that their husband was living a double life or were a drug user. And so we just always just assume that it's that man, but women have to deal with this issue just as well. And so women need to be comfortable being able to talk about it also.
Absolutely. Absolutely. And Dr. Hasbrouck, you said something that was going to lead me into my next question, and this will probably be a very quick response. It's a factual thing. but I think you said it, is that, you know, if you do have HIV and you're on medicine, you still can pass the disease on to somebody you're sexually involved with. Is that correct?
Yeah, that's correct. That's theoretically correct. You know, we're trying to suppress it. It's not, there's no cure for HIV. What we can do is suppress that infection all the way down to very low, undetectable levels, which makes you able to live a more full and healthy life. But you can still, yes, you can still transmit it.
Yes, yes. And that was another thing that my students were kind of pushing back at me and saying, well, if I get on the medicine, then I can still. And so there's a lot of, you know, these myths that kind of, you know, percolate out there in our communities. And it's important for us to listen to experts who tell us, you know, what the facts are. So let's transition into the second part, which are the truths, right? And we talked about, you know, we've been alluding to, you know, these advancements in medicine, and literally, and just to put it out there, there is no cure for HIV at all, correct?
Correct.
Correct. Mm-hmm.
You guys are fast on that.
Listen, if there was a cure, you know about it. Okay?
Oh yeah.
We know about. But you know, because we remember, you know, I think one of the most famous people that ever contracted was Magic Johnson, right? And so, you know, in our communities, we hear these stories like, he doesn't have it anymore. You know, like there's got to be a cure out there, because if you're rich enough, then somebody has something somewhere where I can just live HIV, you know, negative for the rest of my life. So it's safe to assume that even Magic still has some, maybe a small dose, but he still has the disease in him, right?
Yes, that's correct.
Okay.
Yes, he still has to take medication every day. It's just with any other disease that you have, if you have money, then you have access to some of the best care and some of the best quality of care. And so when we look at celebrities and things like that, they have the means to do so, to get the best care, to get the best treatment, to get on early, to get on HIV medicines early on in their diagnosis.
So, you know, another truth, you know, is, you know, people who, and you guys have alluded to this, and I think this is a very important part, because at a certain, probably 20, 30 years ago, when people talked to their doctor and they were diagnosed with HIV, many felt like it was a death sentence. Like, my life is over. I'm never gonna get married. You know, I'm gonna die a horrible death. But as we talked about all these advancements in medicines, people live relatively healthy lives. And I think that, and I want you all to kind of talk about, you know, that. And you talked about the pride parades where, you know, you have the men and the women out there who are, you know, just celebrating life or what have you. But I think sometimes, specifically in our communities, we don't talk enough about that. And so I want you all to just kind of talk a little bit about, you know, the other side. And once you've contracted it, that you can, you know, still live a healthy life. Anyone, jump in.
Well, I'm going to say this: there are few diagnoses that will cause a patient to just gasp and just see their whole life flash before their eyes. Cancer is one, and HIV is another one. It does mean it is a significant diagnosis. It does, as Kevin alluded to, it does mean a lifetime of not only medications, which themselves have side effects, but also a lot of touch points with your doc, because there's all kind of screenings that need to be done, and, you know, immunizations, and it puts you in a high risk group. We're experiencing COVID now. Obviously, folks with HIV positive, regardless of where their viral load is, are still a high risk group. So it is something that says, similar to diabetes, but on a higher level, you know, because you have to get that information and soak it in and ask yourself, what is this going to mean for me, my life chances, my life story, you know, and all the precautions and things I have to take. So it's a burden, you know, so it takes some adjustment, you know, and that's why you know, having a good caregiver that you can begin to build a rapport with and a relationship with, I'm sure Lashannon can comment on this, that, you know, even if the care is expensive, we have standards of care now that ensures everybody gets the right level of care. Even if they can't pay for it, we have, you know, programs to get you medications. So it's a lot to deal with, and it's not a one-off. It's something that requires constant staying on top of it. So it's a whole life adjustment. And obviously, the lifespan or the life expectancy is much longer with something like HIV and AIDS than with some cancers that can be very aggressive. So good news and, and challenging things to manage.
Shannon, you want to pick up on that?
Sure. He talked about gray, just caregivers. There are federally qualified health centers here in the state of Arkansas, also known as community health centers, that delivers team-based care, a patient-centered medical home where individuals that are infected can actually seek treatment. And someone talked about the cost of prescriptions where, in a community health center setting, it is basically, it's a sliding scale fee for your services to where you can be able to qualify and receive 340B drugs, HIV drugs at a discounted rate. So there is opportunity, there are services, and actually Arkansas Department of Health has a huge team that also assists with housing and different other enabling services for individuals that are positive. Arkansas is one of the unique states when it comes to other services that are offered for individuals that are positive.
Anything to add, Kevin?
No, I think they've summed it up. But I also want to say, you can live a long, healthy life, but there are other things that will affect people's lives that would ultimately affect our HIV care, and those are social determinants of health. That when we talk about Black gay men and they're already dealing with the stigma of being Black, they're dealing with the stigma of being gay, and then on top of HIV, it's this whole myriad of different things that can cause your HIV care to go down. And so again, while people can live long, healthy lives, we also need to talk about those social determinants of health. And I think the health department is getting better at looking at those things on the front end, because I feel like once you're HIV positive and you start to give the housing and all of those types of things, it's too late because the people are already positive. And so if we kind of move some of those services over to people who are negative and give those on the front end, they may not get to an HIV diagnosis.
Right. So
I agree with that, but also I think individuals that are positive need to understand the significance of the mental health aspect and being comfortable with sitting down with a therapist. There's that taboo that, therapy, I don't need therapy. Even folks that are not positive don't recognize the importance of sitting down and seeking counseling. And that's something that we're really going to have to deal with in our own community. It is perfectly okay to have that counselor that you go and you talk to just to help you mentally. That is a part of your routine primary care, that person that you can go to and seek care just as well. We tend to, not include mental health services within our primary care, but you need to start thinking about the importance of having a mental health specialist just as well.
Yeah, I think that stems from stigma and all that kind of stuff. My mother, actually, it's funny, like she doesn't realize that she has anxiety and she's had it for a long time, because when someone starts to talk loud, she used to pack us up. She's like, let's go, let's go, let's go. And I'm like, Mom, that's trauma. Those are things that are bringing you back to your childhood that you did not like. And so you're seeing them and you're trying to escape from them. So we're just now finally getting her to see a therapist. And I'm so happy that she's taken the time to actually see a therapist now, so she can get to the root causes of some of the things that cause her anxiety and her trauma and things like that.
Dr. Hasbrouck, you mentioned something. You made a correlation between HIV and COVID in this crisis, and it made me think about something I hadn't thought about before, and I think that you might know the answer to this. But we know that there are a lot of health inequities. I mean, whether we're talking about hypertension, cancer, we know that Black folks seem to be knocking it out the park in regards to those things. So I'm wondering, is there an inequity with regards to Black folk who contract HIV in regards to the correlation of them actually dying or not actually getting the care or the things that they need? If you understand my question.
I think so. I think I understand your question. Is your question that Blacks your question does blacks get it more often, or do they die more frequently from it?
Yeah, more frequently, yes.
That's more frequently.
Yeah.
Okay, so I haven't been close to this data in a minute, but I can tell you by analogy, and you alluded to this in setting up the question, everything from life expectancy to pretty much every single disease, we are diagnosed later in the stage, which means that our prognosis is going to be worse. We die of those things usually much earlier. And because of things like access and care and some of the other things around adherence and health literacy, there's a lot of things to throw in there. We are going to fare worse. The only thing we do better in actually is suicide. But outside of that, blacks and brown folks lead pretty much everything. So I would guess, based on analogy and what I know about other conditions and all conditions, I'm pretty confident in saying that that's probably true.
Yeah, I agree with that.
Then also, I think, you know, we have to look at it from a geographical perspective just as well. And just the South, and when you're talking about comorbidities and just simply, you know, West Coast minorities, black or brown, they understand the significance of just healthier lifestyles, and they don't mind exercising or walking compared to, you know, in the South, there's a lack of transportation or just that public transportation. And so actually getting out to exercise, that becomes a hindrance when naturally, you know, when you have sun, and I was sharing with a friend just the other day because it was raining. I was feeling blue. I was feeling blue because it was dark outside, it was rainy, but I never felt blue on the West Coast because of the sunlight. And I would always get out and go and exercise. So it's just geographically, we have to look at things differently and look at social determinants of health differently in the South compared to East Coast or West Coast as well. So we just can't put it all in one bucket. It varies based on geographical locations.
Yeah. I think it's on our mindset as well, because my big mama will look at us and be like, boy, you too skinny. You need to gain some weight. And I'm like, no, I really don't. Like, my BMI is just fine. I am just fine. But like they said, those comorbidities with HIV and high blood pressure, or HIV and diabetes, or, you know, HIV and unstable mental health, you know what I mean? All of those things can play a huge role in that.
I have several friends that have their therapists on speed dial. And it's okay to have that therapist on speed dial. And we need to be able to have the conversation about the importance of, you know, I think about 100 Black men, just men having a PCP and going to see your doctor on a regular basis to understand not just your status, but just being healthy and whole. That's critical.
I agree. My dad waited 3 years to get his colonoscopy. And I told him, I said, you have to get this done, Dad. You have to get it done. You're 50 now. You live a very sedentary lifestyle. You eat pork every day. You come home from work, you grab your beer and you sit down. And so when he went, they actually found polyps that could have turned cancerous. Mm-hmm. And so it's just that importance of just health overall that we need to embed into our children and into our teenagers. Funny story, I was babysitting my nieces, and it's 4 of them, and they pulled out of their bag all kinds of chips and cookies and candy, and I had made like this big bowl of like fruit for them, and they didn't touch the fruit. You know what I mean? They just ate all of the cookies and candies and cakes and stuff that they brought themselves. And so I think it starts at a very young age. Like we talk about HIV, it starts at a young age, dealing with your overall general health.
Yeah, and I would just add, lastly, the big issue of the health-seeking behavior of men in general, but the health-seeking behavior of Black men in particular. We don't seek that help. We are providers. We have all kind of other stressors and micro stressors of racism and other things going on. We're our own health and actually going to the doctor. We have a healthy skepticism of doctors, even Black doctors. You know, I've had patients that say, well, I want to see the head doctor. And I say, well, I am the head doctor. They say, well, I want to see the white doctor, essentially. So, you know, we have some issues there when you're talking about mental health, you know, or getting that checkup from the neck up, as we say. We don't like doing that. You know, we don't like, you know, mental health, that's a weakness in some ways. And so we have to begin to re-socialize the importance of staying healthy, preventive health. How about doing something on the front end instead of waiting until we have the high blood pressure, we've had the mini stroke, we've had those types of things. So we as Black men have a challenge, and I'm a physician, I've been a physician for almost 30 years now. I don't like going to the doctors. I do it every year, but I don't like doing it. You know, I don't like going to the doctor, and I don't know a lot of people that do, but, you know, we have to have some honest discussion and dialogues about that. We're talking about HIV and AIDS tonight, but it's across the spectrum of health conditions. And I'm glad that 100 Black Men has that as one of their pillars, health and wellness, because that's something that we still need to continue to improve.
Sticking on the health and wellness and the next question I have is around getting tested, right? Why is it important to get tested at least once a year? Some people say, well, I had my test, right? And I got it done 3 years ago. And the next question is, well, how many sexual partners have you had since then? Well, it don't matter, I had my test. So talk to us about why it's important. And even to Shannon's point, like even if you're in a monogamous relationship, when you go and you get your yearly checkup, to still find out your status. So talk to the audience about that, if you can.
I just think it is essential for everyone to know their status. And even if you're in a marriage or a long-term relationship, take that partner and go together so you can get an understanding of the status together. No one should be surprised. Testing services are available. And Dr. Hasbrouck, he gave some good recommendation about just building tools and being more innovative from a digital text messaging perspective that I will definitely, you know, take a look at to be beneficial for the state of Arkansas. But it's just, you need to know. I think about, you know, years ago when I started buying life insurance, and when you get a certain amount of life insurance, you actually have to take an HIV test. And if you want to increase your life insurance, you have to take an HIV test. And so it's just important for each and every one of us that's even on this webinar to know your status and to just make sure you have, when you're getting blood work done, you ask that doctor for an HIV test just as well.
Kevin, anything else?
Oh yeah, I agree with that. Because HIV is such a, I wouldn't say sophisticated disease, but it can be in your body for years and you not know it. So it's very important for people to get tested at least once a year, especially if you're sexually active, and especially if you have multiple partners and you're having unprotected sex, because you could be potentially exposing them to HIV as well. So it's very important because, again, it can lie dormant for so long. By the time you go and get an HIV test, it may be too late. You may be on your dying bed. And so, yes, it's very important for people who are sexually active to get tested at least once a year. I say every 6 months, if you know you're out having unprotected sex and things like that. Now, we do the rapid test at the health department where we test for the antibodies. And so we tell them every 3 months because it takes that long for your body to build up those antibodies to HIV. But I always encourage our clients to get tested every 6 months, especially if you're in that, what we call high risk category, Black gay men, African-American women, LGBTQ overall. I encourage all of them to get tested every 6 months.
And it's not just for your sake, but it's for your loved one's sake just as well. And so you want to, and I think about this because I think about COVID and just people refusing to wear masks, or just I equate that to, you know, if you are in several relationships, the importance of practicing safe sex and wearing condoms, just a mask as well. You want to know your status just as well for your loved ones also.
And the only thing I would add, I'm sorry, go ahead, Kevin.
No, I was going to go out on a limb and say those who don't wear masks, they probably don't wear condoms.
Okay.
So.
Oh, okay. Well, I didn't say that, folks. That's Kevin. What I'm going to say, is I just wanted to touch on something Lashannon said in terms of unsafe sex. Actually, both speakers. What is unsafe sex? Because a lot of people have a different definition of what that can be, and I just want to make it clear that if you're using a condom and that condom is broken, you've now just had unsafe sex. If you're using a condom and it slipped off somewhere along the line, you now had unsafe sex. If you use a condom every other time, you're having so there's a lot of things that can put you at risk. Let me tell you what I do. What I do is every year I get a physical exam. Told you I don't like doctors, but I do it because I want to be around for my daughters. And when I get that physical exam, I get an HIV test. Now, that's what I do. I don't suspect it's going to be positive, yada, 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 but I get it. I just throw it in the mix so I can know my status, as the other speakers have said. So we have to lead by example. And we also have to encourage folks to get a regular exam. If you're an adult over 21, over 25, you need to be getting an annual exam, not just an exam when you're feeling bad, but an annual exam.
That should include an HIV test. You're absolutely right. Yeah.
So brothers, if you're listening, add that to your doctor's list of things to check when we get our annual checkups. Because I must admit, I go every year, and that's something I haven't done before. So I am.
But most men are not comfortable with asking that to their provider. That's why it's so essential that you get a provider to where you feel comfortable with, and you can have that patient-provider relationship where you won't hold anything back. You should be very honest with your physician and let them know every single thing. That actually helps them with their diagnosis of what's going on or what's impacting your health.
Yeah, I agree with that because I went to the doctor and my doctor was like, so are you and your girlfriend having a good time this summer? And I'm like, he just automatically assumed that I was a straight man. And so a lot of times doctors automatically assume that you know your status or you don't want that test. And a lot of times you have to ask for that test. And like Lashannon said, you may need to find a doctor that you're going to be comfortable with talking about all of your sexual habits or your sexual practices. Because I had to actually find a PCP that was comfortable with talking to me about the kind of sex that I have. So that when I go into the doctor's office, the things that I'm talking about are not dismissed.
I will say one other thing, ask about the cost of a test because it's normally not free. It's normally not free. So, I mean, I saw my bill and I was like, what is this? Oh yeah, I got that HIV test, so it's not free. So just ask.
And that was going to be a question I was going to ask around insurance providers. Why isn't it covered under insurance? And does insurance companies cover medication for HIV?
So I'll go with that. Again, within a community health center, federally qualified health center, we see people on a sliding scale fee. If you're uninsured or underinsured, it doesn't matter. We're able to provide those services. From a commercial payer, you're going to it depends on your health insurance plan and what your plan will actually cover. So you really need to take a good look at your health insurance plan to know what they actually cover. And then also health centers, we have 340B drug programs where we're able to provide all patients prescriptions at a discounted rate. Know what's in your health insurance plan and know what's covered. And most people do not take the time to read the fine lines, thin lines, but please do so.
And at the end of the day, it's a simple conversation with your provider at the point of care to say, I'd like to get an HIV test. Is that covered in my insurance? And they can check, they can run that and let you know. There may be a copay, there may be co-insurance. It just may have to be fee for service for that particular test. And so, yeah, just ask, again, this is a part of being comfortable with your provider. No question is too dumb or a dumb question. If you're comfortable, if you have a comfort level and you really want to take care of your health.
If you could say there, Hasbrouck, and answer my question around the drugs themselves.
Mm-hmm.
Common for insurance companies to cover HIV drugs?
Yes, I think it's going to depend on your plan. Once you are, if depends on what point you come into the plan and what the plan covers, you can get it covered regardless of what plan you're in. You may have it already. You may need to top it up or maybe a buy up to get it covered. Perhaps if you come into the plan with a diagnosis and medications, let's say you were unemployed or underemployed and you had to go through one of the sliding scale programs, ADAP, AIDS Drug Assistance Program. Now you're employed, you got a commercial carrier, you bring your record over, and then you get the plan that's going to suit your needs. It's going to cover those medications and cover those drugs, much like with any other condition. You know, some conditions have very expensive medications to treat them, and so it's taken just like that.
So just for the discussion purposes, we are now at the point where we're talking about resources. We went through myths, we talked about truths, and now we're talking about resources. For the audience, if you have any questions, go to the chat box, put them in there so I can ask it to the panelists. I want to go back to something Shannon said earlier. You were talking about mental health and you know, really trying to have somebody in your corner. And it kind of goes to the next question I want to raise around people who have HIV. Are there like support groups for there? Are there Black support groups? Are there things outside of an official like counselor where people come together and gather and just, you know, and also for you, Kevin, you might be able to say specifically here in Arkansas and Little Rock, are there like spaces where Black men or women or whatever can come together and just talk?
Yeah, there are many different resources like that. They have support groups through Our Care, which is all over the state. But we also have some really great ones here right in Little Rock. You have the Living Room Wellness Center that is housed in Southwest Little Rock, where there is a high number of African-American men. You can go and get a free HIV test. You can get access to pre-exposure prophylaxis, which we haven't talked about yet, but we will talk about. And so there are many different resources within the area that you can find. A lot of times it has to do with funding as to why there's not things like that just all over the state. Because a lot of times smaller organizations don't have the capacity to do so because of funding, but it's getting better. And I think with the ending of the epidemic funding that's coming into the state, it's going to get a lot better when it comes to support services and support groups and things like that.
Anything that, well, go there. When you talking about the prophylactics, like, go there, Kevin.
Oh, okay. Well, I can let the doctor handle that.
No, you got it, Kev. You're much closer than I am. I haven't treated HIV patients in a minute.
Okay, so pre-exposure prophylaxis, short word PrEP. PrEP is a medication. It's actually an HIV medication that you can take that significantly reduces your risk of contracting HIV. I would say close to about 95%. If you take it on a regular basis, there are things that you have to do in order to qualify for it. Of course, you have to be HIV negative. You have to get tests done every 3 months to make sure that your kidneys are functioning and all of that, because again, it's still a HIV medication, which is Truvada. Now, Truvada is safe for both men and women, and they've actually added Descovy, which is another HIV medication, to the PrEP regimen, but Descovy is only available for men. And so those are some other tools that you can put into your prevention toolbox that can help you drastically reduce your risk for contracting HIV.
There's a question coming in from our audience, from one of our members, and it basically says, are stats available on Black males without PCP? Shannon,
I'm not sure about that.
Are stats available on Black? There are different studies, national studies, if you're talking about an Arkansas-based study, but yes, there are different stats on Black men without PCPs. And I actually responded saying I would make those stats available and I will send them to you, Mr. Jones. those stats in just different published articles.
And Dr. Hasbrouck, could you give us a picture of how unique or rare Black male doctors are in your profession?
Unique. I will say that we're underrepresented. I will say that the pipeline, first of all, it takes many years to cook a doctor because you got to go through, you know, college, and then you got to go through medical school, and then you got to go through residency training, which might be 3 to 4 additional years. So it takes time to cook those doctors, and you got to get them in the pipeline to even be interested. So that's where your STEM programs, your mentor programs, those types of things. So the pipeline is not as full as we want it. In the profession, at the end of the day, I think there's probably about, the stats are probably somewhere around 6% of doctors are African American, and we know we represent about 13%, so it's disproportionate to our numbers in the population. But the good news is that that African American doctors are 2 to 3 times more likely to practice in areas, underserved areas with African American people, and to have patients of African American background. So when you cook a doctor and you get that doctor out in the field, that doctor is going to be more likely to treat folks in the community, and they're going to be more likely, obviously, to relate to those patients and build a quick rapport, a lasting rapport. And what you're going to find is that improves understanding, that improves adherence, and that ultimately improves outcomes. So it's significant what can happen when you have African American doctors treating all patients, but certainly have them available for African American and other patients of color.
Can I say something, Shannon?
That's correct. That's correct. And so Community Health Centers of Arkansas here, we're actually building up a pipeline, working with University of Arkansas Medical Sciences and different summer programs to ensure that minority students, Black and Brown, have access and just the necessary testing and resources to be able to, that preparation, so they are cooked, have that opportunity to be cooked, to matriculate through the system.
Well, we're coming up at the top of the hour. I want to give each one of you, I want to ask you a question, each one of you, to kind of speak to our brothers right now and provide any advice or anything else that you think that we haven't covered or we have covered that you want to emphasize about the importance or the significance of HIV among Black men. So I'll start with Mr. Holmes.
Yeah, just to recap, HIV again is a chronic disease, and make sure that you're talking to your doctor about getting that test and making sure that you're actually going through with getting the test. Because a lot of times we may not know that we are at risk for HIV. A lot of heterosexual men don't think that they can get it from a woman. And vaginal secretions is one of the fluids that you can actually contract HIV from. Even though it's rare, it can still happen. And so we just need to make sure that we, again, treat HIV like it's a chronic disease and make sure that we're getting tested at least once a year.
Shannon?
For me, it is my hope that Black and Brown men actually have a PCP and recognize the significance and just of having that relationship with the doctor. But I really want our faith-based leaders to recognize it is past time to be able to have conversations like this from the pulpit. We can no longer just go to that back room. It's time to be able to address this to the entire congregation and not just individually, but together collectively. And so if that is one thing that I could say, now is the time for our faith-based leaders to really come together to really create a message, because people still listen to their pastors, and just really educate their flock or their congregation on this subject matter.
Doc, you got the last word.
Well, what I will say is that of all Black folks that have HIV, probably 7 out of 10 of them, or 70%, are men. And many of those men, the large majority, are men who are characterized as men who have sex with men. So that's the whole pie, 70%. But the wedge that's Black women is growing. It's growing, and a lot of that is, you know, is the gay or bisexual man giving it to a heterosexual woman oftentimes and not disclosing. So what I will say as a key is the whole journey or the whole purpose once you're diagnosed with HIV is to get the viral load down, is to get as close to have non-detectable virus in your body, and that will allow you to live a full life. But that journey starts with knowing your status. So getting back to what the other speakers have said, that first step, you know, the journey of 1,000 miles starts with one step. That step is, in this context, getting your status, knowing your status. So you only gotta know it, you know, it's not gonna come through osmosis. You gotta go in and give some blood, you know, and get your tests. And so what I would say as a takeaway, if you don't know your status, or if you haven't had an HIV test in the last year, you need to join the club and get that test done.
Well, I want to thank our panelists tonight. There are a couple of more things we want to do before we close out. Each person who had signed up for this webinar, you're going to be sent a survey. We need you to fill that survey out so that we can get a good sense of how well our conversation informed you and hopefully changing your behaviors around this issue. And then I want to give Mr. Muskie Harris. Hey, Muskie, how you doing?
Hello, good evening, everyone. Can you hear me?
And an opportunity to address us. So go ahead, Muskie.
Well, I want to thank Ms. Spencer for allowing the 100 Black men to be a part of this community discussion. Saving lives will always be important to the 100 Black men. And there's no issue that we won't confront in the community. We think that that's been a taboo to talk about it or be associated with it. And if you know Muskie Harris, you know I will confront it. We will get some results with it. I appreciate my brothers in the chapter for getting the message out. And Spencer, let's get together and let's spread this thing again. And let's just not do it one time. It takes a learning effort to reach everyone. So we did it one time. So let's get together and let's do it again.
I'll also echo, and I'm gonna challenge you, Mr. President. I think all the brothers need to visit her space and get tested. I'll leave that up to you.
Well, I wanted to add something in. I'm getting virtual experience of using computers and communicating. But one part of the message I wanted to talk about is getting the message out to our athletes. They're high profile. They think they're made of steel, and all it takes is one mistake and your whole life changed. So teaching them early about preventive sex and information is a good tool for us to reach out to, and a huge untapped audience.
Well, thank you, Dr. Hasbrouck, CEO Spencer, and Mr. Holmes for this wonderful discussion. We're going to put this video with the rest of ours, and we're going to share it as far and wide as we can, because we think there are other brothers and mentees out here who really need to hear this message. So thank you all for coming out. Yes. And have a good night.
Thank you.
Thank you.